Well, I'm going to start by reminding you of the VENOUS study, which was a multinational cross-sectional survey of the prevalence of venous thromboembolism risk and how well prophylaxis was used in different hospitals. And as I said, this was a worldwide study, and it involved 32 countries, 358 hospitals, and a very large number of patients. We are talking about 68,000 patients. And it's interesting that the average number of patients that needed prophylaxis based on the ACCP criteria was of the order of 50%, up and down a little, depending on the material that was admitted in these hospitals. However, when we looked into the number of patients at risk for venous thromboembolism who were actually receiving prophylaxis, even though they needed it, this varied enormously. It went from 0 in countries such as Bangladesh and Thailand to about 90% in Germany. So there is a great variability worldwide on the use of prophylaxis. And the conclusions of the study was that there's a high prevalence, but there is a need to improve the rate of prophylactic use. So the North American Thrombosis Forum has produced these leaflets saying, we have been educating the doctors long enough. The time has come to educate the public, the patients. And these leaflets are for the public. So when they go into hospital and they're going to have an operation, they say, doctor, what prophylaxis are you going to give me? So that's the first part of my talk. And now I'm going to go to what's coming, what is new, and it's going to be published into the new guidelines that we have been preparing for the last year. And this will appear in January 2013, and it will be a joint publication in Europe with North America in 2 different journals. And we had a very dedicated editorial committee and a very knowledgeable faculty, again, throughout the world, and an enormous corresponding faculty who have been commenting and sending us information how to improve the document. And here is an earlier version of the faculty, one called Morning in London, who worked hard to produce it. And one of the new things that has come in the guidelines this time is the use of Arixtra from the VENOUS. Because in a randomized controlled trial in general surgery of 2,800 patients, there was a relative reduction of 25%. This is in general surgery. And there was a relative risk reduction of 39%, if I can get the curse, 39% in cancer surgery. And in orthopedics, there have been 3 studies, one in hip fracture, one in knee replacement, versus enoxaparin, and they are all in favor of fondaparinux. So in the recommendations for elective hip replacement, for example, we say that fondaparinux, low molecular weight heparin, intermittent pneumatic compression, and gradual elastic compression, and all these treatments are grade A based on the evidence, but we say that fondaparinux is the most effective, that mechanical methods are equivalent to low molecular weight heparin, and mechanical methods plus low molecular weight heparin are more effective than any of these 2. And then, of course, we stress, that's very important, although low molecular weight heparin can start before or after operation, fondaparinux must start at least 6 hours after operation, because if you start sooner than that, you get an increased incidence of hemorrhage. And then we have the new oral anticoagulant drugs, and have a list of them here. Not all of them have been registered. Here they are. And this group acts on factor 10A. And then we have drugs coming up like dabigatran that are antithrombin, have an antithrombin activity. And we have 3 drugs, trabitagran, rivaroxaban, and apixaban, that have come to the market. They are oral, You don't need to have any blood tests to control them because there is a fixed dose response. And this slide summarizes all the studies and is given to me by Dr. Turpey. And on this side of the slide, we have the venous thromboembolism, and on this side we have major bleeding. And the top 4 studies are the studies with dabigatran, 2 studies on hip and 2 on knee. Here we have the rivaroxaban studies, 2 on hip and 2 on knee. And here we have the apixaban studies. And the message is, if you compare dabigatran with enoxaparin, there is no difference in efficacy. However, if you compare rivaroxaban with enoxaparin, rivaroxaban is more effective. And if you compare apixaban with enoxaparin, apixaban is more effective. When you come to bleeding, there is no difference in bleeding here. There is a trend towards increased bleeding with rivaroxaban, and there is no difference in bleeding with apixaban. And that sums up the publications of these studies. Now, what about medical patients? Well, we now have very good randomized control studies so that we can say fondaparinux is grade A, low dose and low molecular heparin grade A, and we have 1 or 2 small studies, and mechanical methods therefore are grade B. And historically, when in the 70s and 80s in medical patients, people compare low dose heparin and fractional heparin versus placebo, there was an 84% reduction in DVT. When they compared low molecular weight heparin versus placebo, there was a 64% reduction in DVT. When low molecular weight heparin was compared with low dose and fractional heparin, there was no difference. However, there was a 52% reduction in major hemorrhage. Therefore, low molecular weight heparin has won the day over low dose of fractional heparin. And finally, with the last study, fondaparinux versus placebo produced a 48% reduction in DVT and pulmonary embolism. And here is the study. This is the Artemis study. And in this study, which was a double-blind, placebo-controlled, fondaparinux was given for 14 days, and patients had a venogram to confirm the diagnosis, and they were followed up to day 32. There was a 47% reduction in venous thromboembolism, composite endpoint, abolition of pulmonary embolism, and a borderline 50% reduction in mortality, BP 0.06. So we not consider that to be significant, but there is a trend. As far as major bleeding is concerned, there was no difference between fondaparinux and placebo. So fondaparinux has come on the scene for the prevention in medical patients. Now, what about duration of thrombophylaxis? Well, we have a number of studies in the past, and we stress them. For total hip replacement, 4 to 5 weeks versus 1 to 2 weeks of low molecular heparin produced 64% relative risk reduction for symptomatic venous thromboembolism. So for hip replacement, you have to go on for 4 to 5 weeks. For cancer surgery, 4 weeks is better than 1 week, with a 60% relative risk reduction. And in major abdominal surgery, 4 weeks versus 1 week produces a 55% relative risk reduction for thromboembolism. So it's no good treating the patient while he's in hospital. You have to extend it while they're at home. And thank you. That's the sum of it. Thank you.